you want to upvote if it's a question you like, and we'll ask those ones first. Just a bit of a background on BASRAT, for those of you that might not be familiar with our work. We're the professional association and regulator for sport rehabilitators in the UK. As part of our work, we host these regular webinars. Some of our upcoming ones with Professor Len Funk, something on the rehab of youth athletes, and many more coming over the next year as well, in collaboration with all of our partners. If you do like our work and you want to support our work, you can join as an associate member. That's open to people internationally. Any MSK professionals that are interested in joining us, just give us a shout. We can send you the link after this webinar. So I will take down my slides. I'm going to introduce you all to Rob. Rob started his career with a BSc in sports science, shortly followed by an MSc in physiotherapy, and became a practicing physio. After several years working in primary care, private practice and professional sport, predominantly rugby, Rob completed an MSc in advanced clinical practice and started working as an advanced practice physiotherapy and as a clinical lead for an integrated MSK pathway. His clinical interests are varied, in keeping with working in his generalist role, but he does have a passion for clinical reasoning and hip pain. More recently, he's had a role in staffing an on-call rota for clinicians to access when they're concerned about serious spinal pathology, including Cauda Equina syndrome. That's why Rob's the perfect person to join us this evening. As some of you may know, he also did a talk recently at Therapy Live, which, if you haven't watched, was excellent. And if you've got a pen and paper, you're going to be taking a lot of notes this evening, because the amount of gold that Rob is going to get through is going to be phenomenal. So my pleasure to introduce Rob. I will hand over to him because it's him that you want to hear from, and take it away.
Thanks, Ollie. Appreciate that. Although I am very disappointed he didn't go with the housekeeping joke we discussed last night about if there's a fire alarm, then that's your problem, not ours, and
yeah,
you know where your own toilets are.
Yeah, I didn't go for a haircut joke either.
Well, that was my next joke, is that I'm not talking about Cauda Equina anymore after this, because every time I do, they seem to shut the barbers. So hopefully we can see my screen.
All good.
You can see the main slide yet?
Yeah.
Magic. Okay, so for those who saw the Therapy Live talk, apologies, there's going to be a little bit of repetition. It has expanded somewhat since then, because some of you were kind enough to send across some questions about particular areas that you're interested in and sort of certain answers that you're looking for. I'll try my best to provide some information. I can't provide concrete answers, but I'll see if we can work through this, and I'm more than happy to hang on and take some Q&A after this, see if we can try and get a bit more clarity. So Cauda Equina syndrome, incredibly rare problem. Unfortunately, some people seem to be red flag magnets, and that's me as well. So I kind of attract people who have serious pathology for some reason. This talk was kind of born out of a demand to just get better at dealing with these complicated issues, because I was faced with them all of the time, and so it was a kind of case of sink or swim. And so hopefully the experience that I've gathered over the last few years can be useful for you in practice, because what I tend to see is the research is largely surrounding those who've had diagnosis of Cauda Equina in things like secondary care and tertiary care, and there isn't really a lot out there on what do we do as a job in frontline clinician. So none of this is meant to replace your own clinical reasoning. That's my little disclaimer. I would always recommend seeking support, and that support can come from your peers, it can come from interdisciplinary networks, it can come from your local hospital trust. These pathways do exist, so learn them, and it'll save you such a headache, because you might think, oh, it'll never happen to me, and sod's law dictates that it will. And once that happens, you don't want to be scratching around for stuff that you should already have knowledge of. It just makes your life a lot easier. Develop strong mentorship, so reach out to people and try and sort of use this opportunity where we're maybe not as sort of busy frontline, and sort of try and talk to people and develop some of the areas that you want to develop your skills in. And if there's anything that I would say, it would be, if it ain't written down, it didn't happen. So you just really need to make sure that your documentation is watertight. And that saved me from two headaches that I would rather not have faced in terms of litigation, where I was asked to come and be a witness for someone who I'd sent to A&E on 2 occasions, and it was 4 years down the line, and I said my notes were of good enough standard that I can't add anything from memory 4 years down the line, so I didn't have to go to court. Just to be clear, you do have to go to court if they're taking action against you. They were taking action against me. They were asking me to be a witness, and I didn't feel like I could help in that way. So anyway, onto the show. So the anatomy of Cauda equina varies person to person, as does everything. So there's some anatomical variance with everybody, but largely it's as the conus medullaris terminates and the Cauda equina then emerges, and that's usually about L1, L2. But again, it just depends on the person. It's a collection of peripheral nerves, and it's not part of the spinal cord itself. And it's in the form of a plexus, much like the brachial plexus, kind of runs down your body like tree roots, and each little nerve has a responsibility for turning on a certain part of the body. And in the Cauda equina's case, it's the bladder, bowel, sexual organs, skin to the saddle region, which is the bit between your legs. Not a bike saddle like a horse's saddle, so where you're touching inner thighs, bum cheeks, perineum, genitals, and the sensation and power to the lower extremities. The syndrome is different. The syndrome has to be a collection of symptoms in conjunction with radiographic findings. So you can have the symptoms of Cauda equina, be it a bladder dysfunction, but it's not necessarily Cauda equina syndrome. It has to have compression of that particular nerve in order for it to be the syndrome. And that's the case with all syndromes. There's a collection of symptoms, but you need to hang your hat on something. And basically the syndrome would involve changes to one of the following things. Would be your ability to empty your bladder, would be your ability to feel between your legs. It would be potential for quote unquote sciatica, whatever that means, running down the backs of both legs at the same time. Loss or altered sexual function, and we'll talk a little bit more about that. Bowel dysfunction and or loss of anal tone, and that's got little asterisks next to it. So it's a key point to think about, because if you are ever handing over to somebody in the case of a suspected Cauda equina syndrome, they may ask you, have you done a PR examination or a rectal examination? And I don't know about you guys, but that's outside of my scope of practice and competence as an MSK physio.
Ditto.
Well, I'll bring on your next slide and I'll tell you why I don't do it. It's not enough to change that patient's direction of travel from my clinic in primary care, in my opinion. So if you look at this graph, and hopefully it's big enough for you to see, this is a collection of symptoms that were identified in people who were known to have Cauda equina compression from this particular study. I've put in this dotted red line as a marker of 50%, and 50% essentially means the toss of a coin. So if it's below 50%, it's worse than the toss of a coin. If it's above 50%, it's better than the toss of a coin. And as you can see, if you move all the way across to the last column, abnormal PR has less accuracy than the toss of a coin. It's not good enough for me, because the time it takes to sort of consent somebody, it's a very delicate thing to sort of expect someone to allow you to do. And essentially, if they've got enough symptoms, they're going. That's the top and bottom of it for me. There's more nuance to it, and we'll get to that nuance, and hopefully that'll help clarify a few bits and bobs for you. Sorry, I forget this is international. Bits and pieces, bits and bobs, a bit of a northern thing. So classification. Yeah, they'll catch up with us. The classification. So I like this classification that was published by Todd in 2017. I think maybe a little bit before that, but this is in reference to the paper that I took it from. And there are 3 main classifications of Cauda equina suspected, Cauda equina incomplete, and Cauda equina with retention. And as you can see, it expands as to how you would classify those things. So somebody comes into your clinic with bilateral radiculopathy, which is a better term for me than bilateral sciatica. So bilateral radiculopathy for me would constitute something radiating from the buttock beyond the knee in a posterolateral distribution. That's because of where the lumbosacral plexus is. It's in the lower end of the lumbar nerve root rather than the higher end, which would encompass the femoral nerves. So bilateral radiculopathy, plus or minus sphincter problems, without objective perineal sensation change. So somebody who comes into your clinic tells you they've got these symptoms in their legs, back pain. They may or may not have problems with their ability to go for a poo or to have a wee, or empty your bowel or empty your bladder, depending on the terminology you prefer to use. And they would tell you, and if you did an examination, you would find that they wouldn't have any changes to the sensation between the legs. Cauda equina incomplete is one of those ones where it's that next step further, and it's this real fine line between catching someone in time and catching someone too late. And I've highlighted this because we're having a lot of problems nationally, I think, as a profession, trying to get people in to see surgeons for decompression through certain hoops that you have to jump, because sometimes you're getting roadblocks in the way of people saying, "Oh, we'll come back once if you start to go into retention." I mean, by that time, according to Nick Todd, that's too late. We've missed a key window to help people get back their function of whatever symptom it is they're presenting with. So the likes of Cauda equina suspected in incomplete, they absolutely should be pushed towards a soon MRI. Well, an emergency MRI, sorry. Terminology like soon is a bit too woolly. So an emergency MRI means same day. Cauda equina with retention, that's one of those ones that also constitutes a same day MRI. So it is an emergency. But there is some nuance as to how somebody might work that up in an emergency department basis. So they may do things like bladder scans and rectal examinations, and that may change their decision as to whether that person gets a scan that night or whether they have to come back the next day. Like I say, learn your local pathway. It will save a lot of headaches. If you've had the inclination to have a look at the Get It Right First Time document, or what I like to call Get It Wrong Less Often, it does go on to look into having a lower threshold for investigation within emergency settings. Not all hospitals and A&E departments have access to 24/7 staffed MRI services. They might not even have a machine. They may have it on the back of a wagon that comes into the car park during working hours. And the other thing is, you might be able to get a scan, but then you might not have a radiologist to interpret the scan. And so that's the key feature. And there has been some discussion as to whether there can be a reciprocal relationship between time zones, where people from the likes of Australia might report on our radiology during the early hours of the morning and vice versa. And that might be a nice little relationship. I think that's a great idea if it ever takes off. But if you think about the potential consequences for missing something like this, it outweighs the financial burden that it would put on a trust to put a clear pathway in place. But unfortunately, it might not be seen as a high priority because it is so rare. But it only takes one. It only takes one, and these things go into the six figures sometimes for litigation. A couple of studies worth looking at, in my opinion, would be the Fontaine study in 2019. It's one of the few ones that cover primary care. Sorry, it's not the one, the few ones that cover primary care. That's a different one. This one covers specialist centres. It's to do with people who already have a diagnosis of Cauda equina. So you're always going to see a higher number. So don't be scared by that percentage of 15.6%. These are people who've gone through the filter. I don't know if you can see me, but this whole filter of every single person with back pain comes into this filter. And then the people who leave that filter with self-limiting, self-resolving conditions leave. And then if you become more specialized, you end up seeing this this densely populated caseload of people with serious spinal pathology. So your prevalence rate is going to be skewed, and that doesn't represent national data for people working in non-specialist centers like primary care, like you and I. But that's the prevalence that's been reported quite recently. A great study to wrap your head around is the Finucane study, which is the positional statement. It doesn't just talk about Cauda equina, it talks about infection, fracture, malignancy. But it sort of recycles an old statistic of 0.04% of people with back pain ever develop Cauda equina syndrome. Me and a few other people who've done some preliminary work on audits are seeing higher numbers of that, but it's not much higher. So it's rare, but there is, I think Alan Taylor would say. This study here by Todd, again, this is a common name you're going to see. He's done a lot of work in this area. Basically looked at 40 cases in his clinic as a neurosurgeon between 2000 and 2009. And what they was looking for is, well, what seems to cause Cauda equina syndrome? So when we have it in clinic, what is it that causes it? And there'll be no surprises for guessing that the largest proportions made up of disc prolapses. There is a fairly high number of stenosis though, and I would ask you just to be mindful of that when you're using your clinical reasoning. So it's much less likely for someone who is 70 and above to have an acute disc prolapse, just because of the anatomy and the makeup and the sort of the physiology that's developed in those 7 decades. It's much more likely in a younger individual, but that doesn't mean it can't happen. So I like to deal in likelihoods and probabilities rather than black and white. If I make reference to, if he ever listens to this, he likes the way I say his name because it's not the way he says his name, David Poulter. He makes reference to the boiling frog analogy, which is if you were to chuck a frog into a pot of boiling water, it would sharp know about it and it would jump straight back out. And that essentially is an example used for when someone has an acute disc prolapse. They very much know about it. The stenosis analogy is when you put that frog in a cold bit of water and gradually heat it over time, and it'll probably stay there for a lot longer. Now, I think I've read a study somewhere that actually doesn't happen and frogs just get out of the water regardless, but it's a really nice analogy, so I don't want it to be lost. But if you think about your stenosis over time, that's going to have some creep and some narrowing with nerve compression gradually occurring rather than a spontaneous onset. But then think about things when you've got an older population who maybe have a sudden onset with a flexion-related movement. They're probably going to have a fracture of a vertebrae more likely than a disc prolapse. And so basically, Cauda Equina syndrome is the compression of the Cauda Equina nerve by anything, something that takes up space, a tumor, a fracture, a bone spur, ligament thickening, anything that takes up space in that tunnel, but the most likely reason is a disc. Yeah, I think I kind of took on this too early on my slide deck, but essentially, if you go back to the example of stenosis, I suspect that there's going to be a subpopulation of adults who have been treated in continence services who have actually had a grumbling Cauda Equina syndrome, who've never had their spine imaged. That's a theory. I've got no evidence to back that up. It's based on the fact that I see people who've had MRI scans and they've never really highlighted the bladder symptoms. But then when you tell them they've got Cauda Equina compression and really dig hard, they bring it up. Oh yeah, well, I've been a bit dribbly for a long time. I just thought it was my age. I've had people in their 30s say that to me before as well. And I really hope that being in your 30s doesn't lead to dribbling because I'm 35. But the thing that you need to sort of get comfortable with is a state of uncertainty. It really is difficult. I'm not here to provide any solutions or single answers. And that's why I really like this paper by Laura Finucane, the positional statement. It really encompasses my thoughts of level of concern rather than yes or no. I've got a pet peeve, and I hope this doesn't offend people, but you cannot rule out a red flag. Can't be done. You can have a lower suspicion, but you can't rule it out. Ruling it out, in my opinion, makes you blasé on your review appointment. So if you've written in your note, red flags ruled out, you're probably not going to revisit them the next time they come in. And these things can happen at any time. And I'm not here to scare you to say this, everyone's a ticking time bomb waiting to happen. But essentially, you do need to sort of have an idea that, I mean, I don't know what your statistics in your own clinic would be, but how many people come back in and largely do well? I'd argue most of them. And then there might be a couple of them that come in and you're like, you know what, last week I was in the garden and everything went pear-shaped. And you're like, oh, actually, now I think about it, there are a few more people who probably do come in and have done something and have got worse. And I maybe should revisit some of those red flag questions just to make sure that there hasn't been any changes. I have a personal positional statement on this. Some of it varies, especially when it gets to the safety net side of things. But I personally think clear language is essential. What I mean by clear language is try not to blind your patients with science and medical jargon. Makes you look clever, but you lose the element of communication. And if you lose communication, how are you going to know what they're trying to tell you? Chronology and behavior of symptoms is key. So when did they start? What's happened since? And what's happening now? Is that normal for you? They're the 3 things that I would really want you to focus on. And the clear language bit also comes to the interpretation of language. I'll give you a bit of an example before when I said bits and bobs. It's a northern terminology, but I imagine it's reached down south as well. But there are some things that people would say that you might not understand, or they might not understand you because you're using colloquialisms. You might work outside of your area. I don't, fortunately, so I understand most of the Geordie slang, but you might work in an area where you might say something like, I don't know, urinate, and there might be quite a low socioeconomic background, or it may be that English is their second language and urination is an alien word, and people don't want to look stupid, so they'll just go, no problems. So use everyday language. Can you have a wee? Can you have a poo? I know it sounds really infantile, but it gets the message across. Other factors are key. So past medical history, we'll get to stuff like that later on with some curveballs and context. So is this normal for you? It's a really good question and it's dead quick. Oh yeah, I've been having some bladder problems for a while now. All right, okay, when did that start? For a long time. Has it changed since your back pain? No, not really. Are these bladder symptoms familiar? Have you had this particular bladder problem for a while? Yeah, this is normal for me. Great. I'm much, much happier. And I don't panic as much because I'm not trying to fathom out, all right, okay, they've got bladder symptoms. Have they got bowel symptoms? Have they got saddle symptoms? And I really don't want red flag questioning to turn into a tick box exercise. There are certain screening tools, not screening tools, some paperwork I've used in my time where it's red flags, no. If they're 70 and they're coming into your clinic with back pain, they've got a red flag. Whether you like it or not, they've got a red flag. It's your job to put that into context. So just don't make it a tick box. Oh, great, no red flags, I can move on. That'll trip you up at some point. And I coined a bit of a statement a while back that you've got to remember that the sensitivity of these questions may shut people down and not give you the answer. So you have to be compassionate with how you're doing your question and how you're priming some of the language you're going to use. So make sure you set them up so they understand why you're asking those questions. And don't be shy. Don't be backwards at coming forwards. Because if you're worried about asking someone about their erectile function just because they're 75, and if you're getting embarrassed, but you missed the one single feature of their Cauda Equina, you'll not live it down. So a red face will only live with you for a minute, but if you miss a serious diagnosis, you'll not forget that. And fortunately or unfortunately, the likes of Chris Mercer will tell you that there's been courses and education built on that single mistake that he made as a junior clinician. And whether it be serendipity or not, I don't know how we would feel about that, but I think we've built a wealth of information, unfortunately, because of cases where people have had their condition missed. So how does it work in real life? It's difficult because I'm making these patients up. All right, put this out there. These people do not exist. Got some examples later on as well of some letters. What might be useful, rather than asking me questions, what would you do if someone said this? Actually bring some examples of this is what a patient has once said to me. What would you do then? Because I can give you a sort of an on the fence answer and say, context is key. I'd want to know more information, and you won't be able to give me that information, so we'll not get anywhere in this. So have some examples set of when you've been challenged by a particular, sentence or phrase or symptom. So the muddy water bit. Doris, she's 60. She comes into your clinic. She's had 5 years worth of lower back pain with intermittent left sciatica. Recently, this back pain has flared up about 3 months ago, and the left leg pain has come back with it. 2 weeks ago, though, the right leg started to hurt. She's had a long history of bladder incontinence. There's been no bowel function changes and no saddle sensation changes. Can you act? What can you do about that? Feel free to put some comments in the comment section. You don't have to come on, you don't have to read them out, but if you want to put yourself out there and say, can you act? Yes or no? I'll give you 30 seconds.
Pop them in the chat box. Chat box, guys, if you want to contribute. And don't forget questions in the Q&A, comments in the chat.
Okay, so I've been suitably vague because that's sometimes the level of information you get. I mean, it's probably more than the information you get on most triage referrals, but that's sometimes the level of information that gets brought to me when someone's concerned. Doris has said this, what do I need to do? Well, I don't know enough. I can't answer your question because that's not enough information for me. So I've missed out certain things here, haven't I? Sexual function. I've missed out the behavior of the symptoms, the rapid deterioration. Are they easing? Are they static? Have they got better? The right leg pain, I purposely put the word right leg because what does that mean? Is it in a knee? Is it in a calf? Is it radicular? So I'd need to know more about the distribution of that. And the recent lower back pain with left leg pain, is that normal? Does this feel like every other episode that she's had over the last 5 years? And that's really key, because one of the, not always, but one of the features of Cauda Equina syndrome is that this is the worst pain someone's ever experienced, and this is very alien to them. They've never had this before. So we're going to split this same patient, Doris, into 4 scenarios. We're going to expand and retract and change some sections within that text. And what we're going to do is we're going to have a little thought exercise and try and figure out how worried are you about this person. So same sort of general gist. Doris, 60-year-old lady. She's had 25 years history of stress incontinence since having her last child. She's never needed any treatment. There's been no changes in their bladder since the onset of this lower back pain and left leg pain. Bowel's normal, saddle sensation's normal. Just to be clear, I don't ask people how their saddle function is, because nobody knows what that means. I ask them in clear terms, have you lost any sensation between your legs when you wipe your bum, when you wipe your front, or in between your legs, between your genitals and your back passage? A good question would be, have you noticed any loss of sensation when you sit in the bath? So you can feel the temperature of the water on your legs, but not in between your legs. That's odd. So certain things like that are good language choices rather than the word saddle. And Sue Greenhoff has published a paper on that very topic, that people have sometimes been missed because they went, well, I don't ride a bike. I don't have any saddle problems. Yeah, going back to Doris, bilateral leg symptoms, new onset, 2 weeks, with right leg pain being in the anterior thigh from the groin to the knee, and it's intermittent, and no foot drop. I stick foot drop in there because it's just good practice. I think someone's got a gripping nerve compression at L5, S1, chances are they could develop a foot drop, and that's also an emergency in our pathway. They need to be seen within 24, 48 hours. So having to think of scenario 1, how worried are you and why? Is it a low worry, moderate worry, high worry? Give you 30 seconds.
See him in the chat again, guys.
Can I see the chat? Hopefully.
Yeah, it should be down at the bottom, mate. Chat box.
Mine's not on the bottom. Let's have a look. More. Chat. Here we go. Okay.
Not many coming in.
Well, we've got somebody here saying I would act. I don't know if that was in reference to the previous one.
That was your previous one.
Lowish, moderate, low.
Low,
okay.
Moderate, yeah.
Fair dues. So again, this person doesn't exist. Don't worry. My opinion on this is that I have a low level of suspicion that this person has something to be worried about. And the reason for that is because she's used the term stress incontinence. I want to know if that's been a formal diagnosis, how she's arrived at that diagnosis. Is it just when she's been laughing, coughing, sneezing, jumping up and down on the trampoline? Seems to be one of the subjective markers that I read all the time. I don't know many people who jump on trampolines. And no changes since the onset of the back pain. Normal bladder function for her. It might not be what you consider normal, but it's normal for her. That's a key feature. Same patient, Doris, 25 years history of stress incontinence. 10 years ago, she had a bladder sling operation, and that failed 3 years ago, but she opted to just leave it and self-manage. Since then, she has poor continence, but no acute changes. She's been constipated since the onset of lower back pain, but has started taking codeine. Has the ability to push and open her bowels. Altered saddle sensation, and when I nudge her a bit further, what she says is actually it's just sore because she's been pushing so hard, she's developed some hemorrhoids. Painful for the last 3 years during sexual intercourse. This is a signpost and opportunity. If you are no longer concerned about Cauda Equina, this, whether you like to hear it or not, in a 60-year-old person or in any age, is a quality of life impact and condition. And if it's painful to have sexual intercourse with your partner, that's not a pleasant situation to be in. People exist to help people in that situation. The pelvic health specialists used to be called women's health physios. I don't know whether you guys branch out into that field or gynecology, but people exist to help people in that situation. That's my soapbox moment. Bilateral sciatica is left leg, and then the right leg pretty much just on the outside of on the hip where the pocket would be, and it's about 4 inches long. No foot drop. So again, are you worried?
Use the chat, guys. Ooh, low.
Somebody's saying, can I ask more about the foot drop? Maybe that's a question for the end rather than for the scenario. Is that a general?
That's going to go in the Q&A. I have written it down just in case.
Okay. Good stuff. Lovely. Good thinking, Alice. Codeine could cause the constipation. Yeah, so good to have these sorts of things in your mind. So I've got a moderate level of concern for this lady. Poor continence, but no acute changes. That's something that I'm not quite happy about. And I'd want to delve a bit deeper into the reasons for that. The thing that really reassures me is has the ability to push bit. There's a difference between constipation and Cauda equina related bowel dysfunction. Constipation, you still have the ability to squeeze your muscles and bear down. You've still got the ability to push using the valsalva and using your muscles in your belly and your pelvic floor. When you lose the innervation to the muscles around your bowel, you no longer have the ability to bear down. And that's not constipation. That's poor bowel motility because you've lost the squeeze muscles. And I hope that makes sense. I'm trying to be as clear as I can on that. Altered sensation. Well, the altered sensation here is pain. And that for me is not in keeping with Cauda equina syndrome. When you wipe between your legs, it's not a pain thing. You may have a hypersensitivity, but it shouldn't be a painful thing. And we could explain those by when she says, I've developed some hemorrhoids. Outer aspect of the leg, 4 inches long, 60-year-old female, possibly more to do with a gluteal tendinopathy, trochanteric pain, whatever you want to call it, not constituting bilateral sciatica for me. So for her, I'd be looking at maybe watching weight with heavy safety net advice so she knows how to act if things changed. Next incarnation of the same scenario, years of incontinence with small volume bladder incontinence, now needing to wear pads for the last 3 months due to intermittent frank incontinence, which is sensationless. So what that means is when she has an incontinence episode, she doesn't know what happens. Constipation for years, further prompting highlights of reduced ability to bear down. And I think I'll probably give you some clues in the previous section there on maybe how concerned to be. This is power loss, not pain, and it's 3 months old. Intermittent numbness of the back passage and genitals during periods of incontinence. So when she realizes she's messed herself, she goes to clean herself and she's numb between her legs. Again, that's been 3 months. Sexual function, she's been unable to reach climax, which is very unusual for her. And that's been there for 3 months. So there's a trend and a theme here, isn't there? Foot drop, catches her foot when she walks for more than 30 minutes. Goes away when she rests. What are your thoughts?
Someone straight in, concerned. Very concerned.
Was that a little open mouth emoji? Someone's from the school of MSN, I can see.
Shame we've got no gifts.
Which one would you go for? Like that one, wouldn't it?
Yeah, the Britain's Got Talent guy.
Okay, scary, yeah, keywords. Right, so these are the reasons why I'm concerned. So I've kind of color-coded them into sort of the higher and moderate levels of concern. So she's now needing to wear pads. That's new, that's different. Sensationless incontinence is not normal. You should be able to feel that you're having a wee. You should be getting an urge that you need to have a wee. Bowel function, she's lost the ability to push, lost the ability to bear down. 3 months is key here, okay? Intermittent sensation changes around the genitals, in keeping, again, 3 months with the onset of the other symptoms. So there's a chronology, there's a timeline here. Things are changing in conjunction with each other. Unable to reach climax, so that's classically sexual dysfunction would be that terminology. Unusual for her, that's the key thing. So in the previous example, when she maybe had painful intercourse, that might not be unusual for her, but this is unusual. So that's what you've got to take away from that. This is not truly bilateral sciatica, it's alternating and intermittent. It's not down the legs at the same time. Still concerned, gives me that some warning signs rather than red lights. Transient foot drop. So there's something not right down there, is there? There's something happening at that nerve root and those nerve bundles that's concerning. My question is, though, what are you going to do about it? This is where the tumbleweeds come through in the chat. Nobody wants to look silly in front of their peers. Refer on. Okay, yeah, I need more than that.
Scan, A&E, MRI.
Okay, run away. Love it.
Run away.
So this is where it gets muddy.
Know your pathway.
Exactly. Know what exists in your local area, because you're all right and you're all wrong unless that is what's happening in your area. So for those of you who are saying A&E, that might not be the right thing to do, because your A&E department might not have an MRI machine. And just if out of interest, if you send someone to an A&E department that's not built for your concern, it costs £6,000 to transfer a patient from one hospital to another. Just let that sink in. People can go to A&E under their own power. So 999 is not necessary unless they cannot get there under their own power. It really does depend on your local pathway, and that's the top and bottom of it. You know, people are saying MRI. Well, can you send for an MRI? And if you can, how? If you work in an organisation that has access to MRIs, is that on site? Is that a private hospital that you can send and it'll be done as an emergency? Because an emergency means same day. Urgent means as soon as we can muster it. Routine is just whenever the waiting list allows us to. And technically, depending on what studies you read, you've got to have this done and dusted within 24 hours, 48 at best. So if you're referring out for an MRI through a private channel, but their MRI machine's broken or needs maintenance over the weekend, and that goes down to 4 days that someone's waited, that might be too late and you're liable. So know what exists in your area.
I'm just going to head off. I'm going to head off a question. Oh, you might literally be about to answer it. That question. If you don't know what your pathway, because I'm still seeing a lot of people saying, "Oh, it might be via GP to MRI," or
most GPs in the UK or in England do not have the capacity anymore or the means to organise an MRI.
Yeah. So, who do you contact to find out what your local pathway is for these urgent spinal conditions? If you don't know.
Shybairns get knee sweets, and what that means in the Northeast is if you don't ask, you don't know. So reach out to people who work in your area. If you know local hospitals have a physio department, they will have a pathway in place, or they should have a pathway in place that they know how to access. Speak to your local competition. Might be a good chance to build some bridges and try and put your heads together and figure out a mentoring scheme between you on how you access it. If push comes to shove, see if you can get in touch with a local spinal orthopedic surgeon or neurosurgeon secretary and say, can I have an email address to ask a question? And how would you like me to act in situations like this? If you don't know and you haven't got time to find out and someone's in front of you there and then, your default position is go to A&E. I'd rather be the mug that gets it wrong, but they're in A&E, which is not a great outlook to have. So to make sure you know where they need to go is what I'm saying, because otherwise you might get a really snotty doctor on the phone ringing you saying, what are you doing? Send this person to A&E. They've had it for 3 months. So yeah, I'm going to repeat myself again. Learn your pathway. Did that answer your question on how you find out about your pathway? I don't want to sidestep that question.
Ask.
Yeah.
Reach out. Ask the local physio department at the hospital. Ask your GP, ask your A&E, ask the local surgeons. Yeah. Just ask.
Ask everybody until you get an answer.
Yeah.
Not everyone on the high street, but just ask everybody who is in a position that could answer your question. And make sure if there is a document in existence in your area, get a copy of it, because then you can put it up on your clinic wall. You can go through it as part of your in-service training on CPD sessions within your organisation, and just get to know it and get comfortable with it. So that was a bit juicy, wasn't it? I've got another scenario. Guess the direction of travel this is going in. If we've started with not very concerned, moderately concerned, quite concerned. Can't leave the house because unable to predict when she's going to wet herself. Has never been like this before. Has not had a normal movement of a bladder in 10 days. Unable to push, again, with loss of power, but this time with pain as well. Not had a normal movement in 6 days, but used to be every day. Can't feel her back passage or her genitals at all when she wipes, all of the time. Too painful to consider sexual intercourse. And that's often an answer you'll get about asking on those things. Last thing on my radar at the minute, son. That's usually the answer I get. Bilateral sciatica, it's constant and it's been there for 3 days. The left foot is flaccid, which means it's a floppy foot. So what I would say for those of you old enough to remember, if you're dealing with people on the telephone and you're asking about foot drop, it's like a thunderbird that's had its string cut. If you know what a thunderbird is, it's a marionette, it's a puppet. So the string's been cut, which means the foot's flopped and it won't lift back up. So it's not a question of how, it's not a question of are you worried, it's a question of how worried and what you're going to do about it. Let's have a look at the chat. Turf to spinal path.
Get them in an operating room, emergency MRI, A&E, with a company letter and call.
Oh, lovely,
Alice is on it. Alice is on it.
You should be leading this talk, Alice. Get on and put something together and you can tour it.
Alice must have seen the slides.
Oh, you better not be a dirty cheater. Right. So everything's red and orange in this one. But if you look at it, can you see my mouse cursor, Ollie?
No.
Oh, okay.
Oh, wait. Yeah, now I can.
There might be. Pointer. There you go. Little laser pointer for you. Is that coming up, Ollie?
Yeah.
Right. So this graph here, we've got this trajectory of something that's been grumble, 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 and then the dam's broken and everything just accelerates at 100 miles an hour. So if you look specifically at the clues in the days, 10 days, 6 days, 3 days, it's almost like a countdown. You know, something. So if it was just those 10 days, then depending on your service area, it may not be considered acute. But the acute diagnosis comes from the onset of the last symptom. So if they've had bladder changes, which are sort of 3 months in duration, and it's a dribble, or it's it's difficult to initiate the stream, but then 24 hours worth of I can't go for a wee, start the clock again, that's an acute onset. And I hope that makes sense. It's about the chronology of the symptoms ultimately. So the scenarios together would look like this on a timeline of events. They've all came on at the same time. Some symptoms have been sort of like spread apart. Some have been a little bit in intervals, and some have been all crammed in a rapid deterioration. And that for me is how that would look. And I'm a bit more visual. I like to see things from a clinical reasoning perspective out in front of me. And that helps me figure out what I'm going to do with this person. So the elephant in the room, duty of care. Do you just do a hospital pass? Goes off to A&E? Job well done. How do you know the right thing's being done? How do you know that they're not going to rock up to A&E and the person you spoke to on the phone has now gone off shift and it's a new person on scene and they've just rotated from cardiology and they know nothing about spines? You've got to put some safeguards in place for the patient's welfare, but also for your welfare. It's a bit drastic, but I like to think that because I've got a mortgage, 2 kids and a wife, I want to continue to be able to provide for them. So you've got to make sure that you dot all the I's and cross the T's. So my questions to you are, have you handed over the duty of care to somebody, and who was it to? An example of that would be a letter plus or minus a phone call, depending on what your local pathway is. Have you documented the name of the person that you've spoken to so that you know the handover has gone to a named individual? And if so, time and date it. We have electronic records that happens automatically. So, but I would say if you're doing pen and paper, that you need to write down the date and time of when you spoke to somebody and who it was. The reason for that is for the next thing. How do you know the appropriate actions have been taken? Well, we must put them on a follow-up call, so we must ring them the next day. Because if they go to A&E and say, yeah, I spoke to someone, they did my reflexes, they said, oh, go to your GP and organise a scan through your GP, that's not the right thing. So you need to ring up and say, why has that happened? Can you explain to me why you've been confident enough to exclude Cauda Equina in this case? Because at the minute, I'm still worried. It takes a bit of bottle to be able to ring someone up, and you've got to know your onions, because some people might talk circles around you. And then, unfortunately, you're racing the whole is, okay, I understand where you come from. Can I just take your name so we can document that this conversation is taking place, please? It's an unfortunate scenario, but that's something you might have to do. And that's where you should seek mentorship and support, because it may be that you have to contact your local GP surgery and go, I'm really worried this person hasn't had the care I think they should have had. Can you help? How do you provide the information to the person? So if you've got like contact information for the local hospital, we have their email address of a constantly monitored email service via the receptionists. We send it to that, so there's an electronic copy of it. We also send it to the patient, because there's nothing worse than them turning up and someone hasn't checked the email and they don't have a letter, and the patient going, I don't know what was wrong with this. He said something about horses. And then the person hasn't got anything to go on. They'd be like, yeah, I'm sorry, don't know, off you go. So if they've got a copy of that electronically, they can download it. Most people have got smartphones. They can download it on the phone and they can go, oh, you haven't got the letter. This is what Rob said. And you can read through it and go, oh, okay, I know where he's coming from. Tell me a bit more about your symptoms. They do their own due diligence, take the history, do the examination. No, Rob's just he's a bit overcautious here. I don't think so. And if so, then they document that. Or no, I agree with them. Let's put the proper pathway in place. Because I might be wrong, and statistics dictate that I'm mostly wrong. So when I send someone to A&E with a Cauda equina suspected, because the prevalence is so low, the likelihood is it's not going to be Cauda equina. But at the minute, it's the best of a bad situation. How do you document what's happened? I'm quite explicit in my documentation. I write things out in full sentences, and I've spoken to Mr. Smith. This is what I've said. This is what he said. This is what we've agreed to do. I've spoken to Dr. Such and Such, this time, this date, this hospital. And it does take a long time, but it's worth it, because that stopped me from having to go to court 4 years ago. Well, it was more than that, probably about 6 years ago now. Not that there's anything wrong with going to court as a witness. I just didn't want to be there, if I'm honest. It's not a nice environment to see someone having to battle for something that should have just been taken care of. How are we doing for time, Ollie? I've lost track.
All right. We're going to run over, but you know.
Safety net advice then. This has got a big exclamation mark behind it, because my preference of safety net advice is much, much more over the top than a lot of people would do. I give every single person with back pain in my clinic, I ask them questions about Cauda equina, whether they've got leg pain or not. They all get, or as much as I remember, which is 99.9%, I may get distracted in the conversation, they all get a safety net leaflet. You can find something like this via the MACP leaflets that were put together. The hyperlinks there, but I forget the name of the hosting site now. Dynamic Health, that's what it's called, Dynamic Health. And it's in lots of different languages. So I've even sent somebody who was going to Spain on holiday in a week's time, I've given them the Spanish version of the Cauda equina leaflet, just in case, because they might want to access it. Now that sounds like over the top, but and what I get pushback wise, it's like, you're terrifying everybody to go to A&E and you're making them worried. That suggests that you have low confidence in my ability to have a conversation with another human being. And I'd like to think that, because I put things into context and prime them, probably less sort of scary than I am in this conversation here. It's rare, but there. I need it to be vigilant rather than worried. It's a good idea to know what to do just in case. And there are times, and I can sort of see it on 2 occasions, where people who've had back pain and no leg symptoms and nothing else have then later gone on to develop Cauda equina syndrome. And if you don't safety net that person just because they don't have leg pain, they may have leg pain at some point. You might have just caught them at the wrong time of their disease progression or condition progression. So how would they have known what to do if we'd have just discharged them without giving them any safety net advice? It's a public service thing. Got a cough for more than 3 weeks, you should see a GP. Got blood in your stools, you should go and see a GP. It's just general education stuff.
It's the aeroplane safety briefing. 99 times out of 100, you're not going to need it, but we tell you because if you do, it's really important.
Yeah, exactly. And it does sound a bit over the top, but I'd like to think that it's done in a sort of in a way that it comes across as empathetic. It's just a little bit of friendly advice. And I've not had any complaints from A&E saying that we've been flooded by people with your leaflet waving it in my face because they want an MRI scan. Because I don't tell them they should go to A&E for an MRI scan. I tell them they should go to A&E for an opinion. And what they might do is they might investigate between your legs, stick the finger up your bum and scan your bladder. Now that's enough to put a lot of people off going unnecessarily. But it's documented, it's there. That doesn't make me bulletproof from any legal action, but I think it makes me a little bit more robust. One of the pushbacks I get is, we don't do that for AAA, do you? You don't do that for a septic knee. And the reasons I don't do that for those things is because there's clear demographics of who that of those people who that affects. If they're a heavy smoker, overweight and male, and they've got belly pain, I might safety net them for AAA. Whereas Cauda Equina can affect anyone at any age, and there's no clear demographic. So until there's a better demographic and we've got better data, I'm going to continue doing what I'm doing. That's my second soapbox moment. There might be a third, I'm not sure, I haven't decided yet. Curveballs. So what if they've had cancer? It's a different kettle of fish again, because metastatic cord compression is a real thing. Again, it's a rare thing, but it's there. And it may change how you act and who you contact. So A&E ultimately could be the correct direction of travel for a lot of these people. But there are services that exist called the Metastatic Cord Coordinator. And I would suggest ringing your local hospital, getting through to the switchboard and saying, can I be transferred to the Metastatic Cord Coordinator, please? And seeing if they exist. And then say, hello, my name is such and such. Just want to know if you existed in this area and how I would access your service if I was faced with a situation. And they'll give you the information. I've got their direct line in the region, I've got an email address for them. It just makes life a lot easier. The Metastatic Cord Coordinator can help guide you through how worried you should be, because I'm not an expert in cancer. If someone's had breast cancer, that could be a well-confined local lump that didn't need any treatment and they just monitor it. Or that could be a massive malignancy that they needed a mastectomy and a prophylactic mastectomy, and their children needed mastectomies without having had breast cancer, but their genes were there. Or it could have spread into the lymph nodes, could have been a delayed diagnosis, could have been there for a long time. All of these increase the risk of metastatic disease. The metastatic disease is just the spread of cancer to the bone. Well, not just the bone, but in this case, the bone. So what if that person says to you, oh, I've had an MRI? Well, I want to know when that was, because if it was in 99, it doesn't tell me that you haven't got Cauda Equina now. And even if it was 2 months ago, was that before you started wetting yourself? Was that before the erectile dysfunction came on? Because if it was, it's redundant. Not completely redundant, but it's largely redundant from a Cauda Equina perspective. What might be good to know is 2 months ago, did that MRI show that you had a large degree of stenosis or a central disc bulge? Because the likelihood is if you had something like that, then it wouldn't take much to progress to explain those symptoms. Now, don't get me wrong, we are very robust individuals. We wouldn't have made it this far as a species if we weren't. But things like this do happen. We do have consequences of disc prolapses. We do have consequences of fractures or malignancy. So it's worth knowing about it. And you can't diagnose something you didn't know existed. So if you kind of cast your net wider and have a little think about other things that you might want to read about topic-wise. What if they've said, oh, I went to A&E? Well, I'd want to know at what stage of your condition that you went to A&E. Did you have the symptoms you have right now? And if you did, what did they do about it? Did they just do oh, he's been in the corridor 4 hours, better get him in, quick reflex check. Yeah, can stand on his tiptoes. Off you go, son, you're fine. Or did they do a full bladder scan, pre and post void, a rectal examination, an MRI in clinic, or even a CT scan if they didn't have access to MRI? I'd want to know what was done. The top and bottom of it is I'm a nosy prick. And so the more questions to ask, the more information you get. The problem with that, though, is you've got to know what to do with it. And if you get a lot of information, you've got to process it. So there's a balance to be had. So my take-home messages would be, personal information needs priming. If I come in and Ollie's my first patient, hi Ollie, my name's Rob. How's your erectile function? Probably not the best way to start a conversation. It's probably a good way to get a litigation. I would say to Ollie along the lines of, thanks for telling me a bit about your back pain. Do you mind if I ask you some questions about the situation? I've never had anyone say no. So hopefully that doesn't happen to you. So I would say to them, there's some nerves that live inside of your back that turn everything on from your belly button to your toes. When those nerves are not working, it presents in a certain way. And that means we have to act in a different speed. So what I need to know is the function of your bladder, bowel, skin between your legs, genitals, and your legs. And then I ask them in plain English, have you been able to have a wee? Can you keep it in when you want to keep it in? Does it come out when you want it to come out? Does it feel like it comes out with the same speed? Can you stop it if you need to? Can you feel it when it's coming out? Same question for your bowel. Has there been any problems being able to push? When you wipe your bum, wipe your front, wash in between your legs, can you feel that the tissue's touching your legs or the water's touching your legs? If you're still sexually active at the moment, has there been any loss of sensation during penetrative sex or inability to reach climax? It's a bit of a catch-all because it's not just women who have penetrative sex. You've got to make sure that you do understand that, because people who have the PR test is to look for any sort of muscle tone loss in your back passage. That might be something relevant to them. We've had people come in who say during anal sex, I can't feel. That's worrying. They're worried enough that they've volunteered some quite personal information to you. Where did they get to? Leg pain. Have you had any pain running from your bum down to your foot and both legs at the same time? Have you had any floppy foot? What I mean by that is, as your puppet string being cut and you can't lift your toes up and lift your ankle up. And that's generally not at that speed and not in continuation. That's generally how I would voice those questions to people and stop at each segment, give them a chance to answer. They're not diagnostic questions, they're springboard questions. They allow you to ask for deeper context. And if anything, they're signposting opportunities. And you cannot move on until you are happy that this person does not have a quality of life impacting condition. Finer detail also helps you when you hand over to your medical colleagues in the A&E department. If you write a crap letter, they're likely not going to get the right thing done. So think, has your duty of care ended? And I would go back to seek support, learn your local pathways, develop strong mentorship, appropriate documentation. And this disclaimer does not replace clinical reasoning. The buck stops with you, I'm afraid. Now that's the end of the original talk, but I do have some additional slides because I know somebody or a few people on the pre-talk questions wanted to know, how do you write letters? How do you safety net people? Do you use performers? You will get a copy of all these slides, and I've got some examples of how I would structure a letter when I'm concerned, how I would structure a letter when I'm going to scan them, how I would structure a letter when I don't have a concern about Cauda Equina. And if you want, we can go through it, or you can read it in your own time. I'll leave that up to the chat and Ollie's thoughts.
I think on the basis that we've got quite a few questions in the Q&A, and we are going to send out the slides to everybody. So you will have access to the hyperlinks, you'll have access to all the references that Rob's used.
The references are here.
Yeah.
In the slides. The handover examples are hard to read on here. So I'd read them in your own time, essentially, is what I'm saying.
Yeah, so we'll give everyone the slide deck. There's tons of information there, which is brilliant. So I think on the basis that people are going to get that anyway, we will jump into the Q&A.
Sorry for running over. I got carried away.
No, that's fine. That's fine. Better to hear it. And the chat's on fire as well with compliments. If you would like to feed your ego this evening, you can go and have a read of those while I get these
screen grab them and show them to my wife. Look at this. People think highly of me outside of this home. Thank you very much, guys.
Alice, your favourite is top of the question.
SWAT. Well. Come on, Alice.
Which it's got quite a few upvotes, so there's a few people. So it's a two-parter because she's added to it. Does it absolutely have to be bilateral sciatica, or can it occur with unilateral leg symptoms? Yeah, so we're getting nods already.
You can have no leg symptoms.
So
the real kick in the teeth is you can have it without back pain as well.
Yeah, so she said, as a kind of add-on, she said, I feel like it's been answered now, so you were touching on it earlier. What's the lowest threshold for referral, moderate or high?
Ask that again. I don't know.
So I think she's referring back to perhaps with our scenarios. So she's saying, like, if someone was, fell into moderate, so say scenario 2, 3.
Okay.
Versus high. What's your lowest threshold?
It's the time scale rather than the moderate to high. It's basically, I might have a high suspicion that they have Cauda Equina compression, but because they've had it for 3 months, A&E will want nothing to do with them. So it very much is dictated by what pathway exists. And because I'm in a situation where I'm fortunate enough to have access to MRI, fortunate and unfortunate, it's a double-edged sword, because if I choose to image somebody, then the responsibility is on me that I haven't delayed their care, because I don't have emergency access, I have soon. So if I image them and it takes 2 weeks, 3 weeks, then it's my problem. So essentially, I've got to be happy with the level of accountability I'm inheriting, but the patient has to be happy with the level of accountability they're inheriting as well. Because believe it or not, people sometimes don't go to A&E. I've had people that flat out refuse, despite me telling them what the consequences are. But you've got to document that. You can't say, oh, I encouraged them to go and they didn't want to go.
Yeah, clinical records have to be.
I asked Mr. Smith about his Cauda Equina symptoms. He's told me this. I'm concerned. I cannot exclude Cauda Equina syndrome. I've told him he needs to attend the A&E department. He has refused, despite understanding the consequences.
Cool. Right, Tanya, foot drop question from earlier.
Floppy foot.
So I did write it down, but she also posted it. Can you expand? Go. You include it.
Are you talking to me or Tanya?
I'm talking to you.
Oh, right. Okay.
So
if you think about why a foot drop occurs, it's usually either something's pressing on the nerve root or something's pressing on the peroneal nerve. Usually. There's other reasons, of course, upper motor neuron lesions, demyelination, but it's usually there's some pressure on the nerve somewhere. And it's most commonly affected at the L5-S1 or the common peroneal nerve. So if someone's got a floppy foot because of a nerve root lesion, that is an emergency. It needs decompressing. If you miss that boat, there's, depending on the neurosurgeons you speak to, there's a chance that they'll just ride it out and get better by themselves, and that may happen. There's a chance they'll never regain the function of their foot and always have to rely on a foot drop splint or a foot up splint or an AFO or whatever you're using in your area. So I include it because it's an emergency and because it's usually there because of the thing I'm concerned about with Cauda Equina, a large space occupying lesion pressing on sensitive structures. So that's why I include it. And I'm not sure if I've answered your question, but I've just took a gambit on what you mean by expand.
I think that'll cover it, or certainly at least direct some thinking that they can do to follow on. So Khaled with a belter of a question. I've read it a couple of times because I wanted to be able to pronounce it right. I will admit this. What's the difference between a Cauda Equina syndrome and a conus medullaris?
Thanks for that. It's the site of the lesion. So is it pressing on the Cauda Equina nerves or is it pressing on the conus medullaris? And so I don't propose to have a great idea of how to differentiate that clinically, but it will usually manifest in ways that make me concerned. So because it's within the cord, it might present with more upper motor neuron lesion signs rather than hyporeflexia, hypotonicity. So you might find you get a mixed bag worth of upper motor neuron signs and lower motor neuron signs. Ultimately, they need an image, and it's for some people cleverer than me to do something about.
You're spotting it. Great question again from Tanya. Love this one because it's the links back to the quality of life thing we talked about. So painful sex, no low suspicion of Cauda Equina. Is it a referral to the GP or is it local incontinence clinic? She said she's a private practice GSR. So
for painful sex,
yeah.
Continence clinics might confuse the matter because they're sometimes staffed by continence nurses who are under urology. There may not be a urogynecology service in your area. You may not have access to, pelvic health specialist physios. And I know that's a dirty word in this environment, but there are a group of individuals at most hospitals who deal with pelvic health conditions, and that's much more than just continence. So painful intercourse can be for a number of reasons. I don't want to be crude, but for example, it could be dryness, and that's the issue. And the GP may, for example, guide on lubrication or medication to help with that. If it's to do with scarring following a surgical procedure or some tearing or abrasions after childbirth, you're best off going down your sort of pelvic health physio route, if I'm honest with you. There are people who work in private practice who specialize in that. Certainly there's a couple in the Northeast who I would liaise with, and when I work privately, if this wasn't my bag, I'd be going, you need to go to this practice because they know much more about this than I do. I have an awareness of it, probably more than your average MSK male clinician, but I still don't know what to do about it. So I know what's not my bag, and as a result, I signpost to people. So the painful intercourse just depends on what the reason is, and you might need to ask.
Yeah.
And they might volunteer. It just hurts. It feels like I'm tightening up, like a spasm. Well, that probably suggests more muscular. Therefore, you might want to go and see the pelvic health physios. If you're concerned about their past medical history indicating that there may be a pelvic mass, you probably want to go via GP first, because they might want to instigate some investigations like pelvic ultrasound, CT scan, X-ray, bloods.
I think there's another thing here as well, isn't there, of know what's around you. Learn who your colleagues are locally, be it private or, in the NHS. And if you've got local pelvic health specialist physios around, get to know them. get in touch, and
Definitely.
you can reach out, you can ask the question, and they'll go, yeah, well, you can send them to me, or actually that sounds like it's a GP job, or whatever.
I mean, a good place to start is a Facebook group. There's loads and loads of Facebook groups of professionals out there who have special interests. So there's a men's health and women's health Facebook group that I'm a part of. Helps me keep an eye on what is going on, what exists, and who exists in my area. And if I don't know, I put it on there. Does anyone know someone from the Northeast who specializes in X? Oh yeah, this clinic. Or actually a little bit out of area, would they be willing to travel? Okay, I'll put it to them and I'll find out.
Exactly. There's loads more questions, and I'm not going to cover them all. So
can you copy the chat and maybe just try and get through some of them? And if they've already been answered, I have been on a podcast because of a similar scenario where there was loads of questions and we asked them to follow up.
What I was going to do is plug your Twitter for people who are on Twitter. So yeah, at Combat Sports Viz, aren't you, on Twitter?
Yeah, it's on my.
It's on the bottom of your slide. I've got it on mine, which I can throw up. And obviously we're going to email everyone after this with the resources anyway, so we'll signpost them to where they can get in touch. Because I'm guessing that people are going to want to ask. And just it was the Physio Matters podcast you did the follow up to Therapy Live, wasn't it?
Yes, Tom Jessen. Dragged me over the coals, and we invited he did. He sort of like, oh well, we've got some really we've got some really challenging questions that I didn't get a chance to answer. Here they are now. Speak.
Yeah.
And so you put that in front of me, and
so
go from there.
I'll dig up the link for that, and I'll put it in with the resources as well. And I'll give him a plug. I think Rob Bevan did a CES podcast recently as well.
That was with me as well.
Yeah.
Yeah. Unfortunately, I've become a bit of a mouthpiece because I'm a bit of a gobshite. So people ask me to come talk on things, and I just put it out there that I'm no expert. This is just 11 years worth of what I've learned.
So let's round it off with one more question from Charlotte, because I think it's a nice question. If someone's already gone to A&E, they've had minimal testing and been sent on their way, but you're still concerned as a clinician, do you send them back to A&E, or do you go down another route?
You can send them back to A&E. What you've got to be clear of, though, is when you ask the patient what's been done, you have to be happy that what they've done is a fair representation of what they've said's been done is a fair representation of what's been done. Now, most people are going to remember that they had a rectal examination, but it's been known for people to say, well, I don't think they did that. And then you find out that on the notes that was actually done. Now, whether that's somebody said that and it hasn't been done, there's a lot of sort of he said, she said. If you're still concerned, send them back. If you're really concerned, pick up the phone and speak to someone and express why you're concerned. And it may be that they've had a very good reason for not doing the thing you think should be done. It may be that they don't have access to MRI. It may be that they've spoken to an on-call spinal orthopedic surgeon who's come down to the A&E and examined them, and they're happy. And they've booked them in as an outpatient for 3 days' time or whatever. I mean, that's your duty of care complete. I don't think you can't do much more. You can't exactly drive to their house, pick them up, take them to A&E and sit with them.
In. Yeah, and then speak on their behalf. Not possible. I'm just going to stop sharing your slides, sorry, mate. No, you're all right. I'm going to chuck mine up there. Have a read through the chat, because seriously, some of the comments are amazing. You're getting a lot of love, which is brilliant. What we're asking, I'll tell everyone in a second as well, but we are linking everyone to a survey afterwards that people are going to get automatically directed. So I'll pass on the feedback, obviously. As I've just mentioned, when you leave the webinar this evening, guys, or when we boot you out, you should get a survey that pops up. It's just a Google form. It's a little bit of an evaluation of tonight's session, a little chance to leave some feedback for Rob, all the nice stuff that you've put in the chat.
Or even the horrible stuff.
Or even the horrible stuff.
Skin. In the Northeast, you have to have thick skin. So I genuinely, if you think that there's some things that I've glossed over, could have done better, send them my way. You can do it anonymously as well if you prefer.
They can't. Can they? Yeah, they could leave the name.
They can
off.
Send it to you.
They could send it to me. I can collate the abuse. Yeah, that's fine. We'll be sending out certificates to you in the coming days. Be a day or so. but we'll collate all the resources. I'll get Rob's presentation from him, and we'll get the recording ready and give you access to that. As I said earlier, if you're not already a member, you'd like to support Basrat's work and you'd like us to help deliver more of these sessions and put them on for free as free CPD, please consider supporting our work. We'd really appreciate it. If you have follow-up questions, as I said earlier, there's Rob's Twitter handle @CombatSportsViz. I know you're not all on Twitter, but you should be. It's a great place to learn. I know. Can you believe it? It's a great place to learn. It's a great place to get access to resources, and a great way to ask people like Rob lots of difficult questions.
And spy on people when they're having ego barneys. That's quite a nice way to pass the time.
Exactly. Yeah, but never get involved because it just blows your phone up. If you want to follow Basrat, we're @Basrat.org. We're going to leave it there because we have gone over.
Sorry.
As we always do. That's fine. Rob, thanks so much for joining us, for sharing your expertise with us, for answering people's questions, for a brilliant presentation. I'm sure it's been really valuable. The way I always like to think of these things when we cover really serious stuff like Cauda Equina is, if this helps to prevent one serious case of CES and catch one case of the 300 and odd people that attended live this evening, then it's been absolutely worth it. The feedback's been incredible. I'll pass it on to you, and I'm sure lots of people will be in touch. We are going to get booted out rather abruptly, because when I hit end, it kicks everyone out and it kicks me and you out. So we'll leave it at that, and I'll see you over on Twitter.
Thanks for your time, guys. Sorry to eat into your time in an evening.
Cheers, Rob.